adults with congenital heart disease, and we have to take into consideration of alternatives like ductal stenting or right ventricular flow throughout stenting. Just to have a look of different pathologies, the most important for biventricular repair or monoventricular repair. Tetralogy of Fallot. Another multi-center study. They analyzed 3,000 tetralogy of Fallot. Neonatal repair just in 6% of patients, so it's not so widely used to do neonatal repair. And the best results in terms of mortality and morbidity when it's performed between 3 and 9 months, and no benefits of neonatal repair over BT shunt. So, there are clear indications for BT shunt in tetralogy of Fallot. Low birth weight patient, less than 3 kilograms, between 3 and 5 kilograms, so before 3 months of age, when the patient is severely cyanotic, small pulmonary arteries, when there are anomalous coronary artery, other pathologies associated like complete AV canal or multiple VSD. But these are the same indication for right ventricular flow tract stent. In favor, in our opinion, of BT shunt is that BT shunt is a standard procedure performed for 70 years. It's easy to perform repair of tetralogy of Fallot after BT shunt than right ventricular flow tract stent. And these patients have a less incidence of transannular patch at the time of repair for 2 reasons, one mechanical and one for flow mechanism. Mechanical is quite easy. If you put a stent on the right ventricular flow tract, it's impossible to save the valve when you go to do the repair. And the flow mechanism is quite interesting. This is a nice paper from Japan. And they compare BT shunt and primary repair tetralogy of Fallot. And they show that in the... I have to stop?
Maybe it's better just to stop and you
come
back.
Okay.
Yeah, okay.
Yeah.
That's, otherwise...
I cannot run too much.
Okay, so we interrupt Dr. Giamberti and we can go to San Donato. Mario, can you hear us? Looks like the team is ready, all dressed up.
Hello?
Yeah, hello Mario.
Martin?
Yes, it's me.
Good morning. Okay. Can you hear us and see us?
We can hear you, we can see you.
Okay, very well. Just very briefly, may I introduce my co-workers here. On the back, Luca, Junior, Massimo Chessa, and a special guest, Gregor Krinks, who's been our mentor in starting to use 3D rotational angiography. So that's our great pleasure to have Dr. Krinks with us today. So we go straight to the presentation. Let's move to Francesca Pluchinotta, who's going to present to you the case. Francesca, please go ahead.
Good morning, everyone. So this case is a young lady, 21 years old. She weighs 53 kilo and is 165 centimeters high. She has been diagnosed as a neonate, as a pulmonary atresia with ventricular septal defect, and at 2 months of age, she underwent a right BT shunt. At 2 years of age, in 1995, she underwent surgical replacement, a surgical replay with an aortic homograph from the right ventricle to the MPA. In 2001, the conduit was replaced with a shield height 23 millimeters. During follow-up, there was evidence of progressive conduit calcification and pulmonary valve incompetence. So on October 2014, she was treated here. We put a conduit stented with a, we stented the conduit with a CP-covered stent 45 millimeters mounted on a 25 balloon, and then we put a stent on a RPA mounted on a 23 balloon. Here is the angiography showing the calcification of the conduit and the stenosis at the origin of the RPA. And here is the angiography post-procedure showing the stent on the MPA and another stent at the origin of the RPA. Here is the CT showing again the waltz-in conduit on the MPA and stented conduit on the MPA and a stent on the RPA. We took measurements from the CT, and actually the conduit seems to have an oval shape. as you can see from these slides. And finally, from the CT, a 3D model was created and printed by Materialize. The model is seen here. Here we go. As you can see, this is the right ventricle outflow tract. You can clearly see the stent on the RV, OT, and on the MPA. And this is the other Andra stent who is going on the right pulmonary artery, and it seems a little bit to jail the left pulmonary artery, but as you will see from the angiography, the flow on the LPA is not obstructed at all. You can nicely see from this model the coronary arteries. Here is the coronary artery far away from the conduit, and here you can see the left coronary artery that is not touching by the conduit and the stent in the conduit.
Okay, thank you very much, Francesca. Well, just for people who are interested in seeing a copy of this 3D model, you may visit the booth of Materialize, and a copy of this model that Francesca showed you right now is available for you to play with it, have a look directly and touch in, etc. Okay, so now we started the catheterization, we measured the pressure, etc. The right ventricular pressure is just above the limit, 35 millimeters, and we did some angiogram. Can we lower down the lights a bit? Can we show the first angio, please? Can you see the AP cranial?
Yeah, we have a nice view.
Yeah, with good flow in both pulmonary branches and, of course, severe regurgitation. Okay, next. That's in the lateral view again. You see, in the lateral view, the size of the stented conduit is a bit less as compared to AP, but not that much. We measure 19.5 in the lateral view and 21 and something in the AP view. So it is slightly conical. So, okay, so the next step we did was a 3D rotational angiogram. Gregor, would you like to comment on how we performed the 3D, etc.? Please, Gregor, go ahead.
So, since it was known that the left coronary would be the coronary which was a little bit more close to the stent, we decided to take a selective left coronary injection with 20-25 cc of 60% diluted contrast. Of course, in this case, it was known from before that there was no interaction, so the 3D demonstration now is more for demonstration purpose and not really for the, well, let's say, process of the procedure. At the same time, simultaneously, Mario was using a pacing electrode in the right ventricle to pace with a frequency which lowered the blood pressure down to 50% of the initial value, to create cardiac output being reduced and to make the contrast stay at its place of interest a little bit longer, which would enhance the contrast density. We see the right ventricle injected. We would never inject the PA. The right ventricle injection on the rotational shows us well, the RVOT and the stents and the RPA and the LPA. So if we look at the rotational, it looks pretty nice. Everything is there. We had a 2-second start from the injection before the 3D acquisition. 5 seconds would go ahead. Now Mirella will show us how the 3D image looks like. Of course, this 3D image could be a CT, it could be an MRI being brought here on the cath lab by merging techniques, or as we demonstrate now, it could be 3D rotation. Mirella will show us that if we use the threshold, which only shows metal, these are the two stents, a CP stent and an Andra stent. You can work nicely around.
Well, can you go back? Can you go
Mirella,
to
stay with the stents, Mirella? Only stents?
Yeah. Are you seeing the 3D reconstruction?
No, we only see the,
No.
here's the 3D reconstruction.
Okay, now you see
What
the
they are
3D reconstruction.
seeing is on
Okay,
that
okay,
square.
I got it. So now, well, Mirella, just show us the stent and rotate a little bit. So it's the Andra and the CP. The purpose from this here is just if you have stents where you in CTs could have a lot of scattering, you could find your way to work around in a 3D rotational to still be able to see the stents. Now, Mirella, could you give us your PA, LPA, so some more soft tissue? So there's a pulmonary artery situation on the left, on the right. We cut it away a little bit from the periphery, and you will see the stent RVOT relation and the bifurcation. In smaller patients, this can be much nicer, being more detailed. We had some issues with the pump not being able to give more than 100 cc. So this is done with 60% contrast. The amount was 90 milliliter of 60% diluted, so more or less, let's say 55, 60 milliliter pure contrast. Mario did the conventional angiogram with 35 milliliter.
Yeah.
So now Mirella will show us the other guy coming there, the orange one, which is of course the coronary, and you can play with both of these figures in one scheme and work with them independently.
Yeah, it looks very nice to me. Of course, in this particular case, because of CT, pre-catheter evaluation, 3D reconstruction, etc., we already knew that the coronary was far away from the conduit. So this is just more for educational purposes. But in cases where we are in doubt about the position of the coronaries as compared to the RV outflow trial we're going to stent, I think this is going to be very, very helpful. I mean, you can see in different projections. Usually, before I started to use the 2D rotational, I used to do several angiograms, several injections in different projections to make sure about the position of the coronary as compared to the as opposed to right ventricular outflow trial. But this, with a single injection, well, in this particular case, we did the selected left coronary, but you can also do simply an aortogram or left ventricular angiogram and simultaneously looking at both coronaries and their relationship with the RV outflow trial. Yes. Any other comments, Gregor?
No, not really. So.
Dietmar has a comment. Dietmar.
Yes.
Can you put on the microphone there?
I have a question concerning the left pulmonary artery. You didn't dilate the struts of the ultrastent, and my question is behind, can you estimate the amount of the left and right pulmonary flow by the 3D angiography? Can you make a decision, should we open the cells or let it closed, or give a comment from your experience, please?
Well, I think as you are much more experienced than I am in conventional angiography, and due to the fact that the basics of rotational are nothing else but conventional, the answer, of course, is that you cannot judge using a rotational if there's really, I mean, much. Well, you can say if there's much more or much less perfusion. So a rough relation, yes, could be given, could be estimated. But Dietmar, of course, you would not reach something like scintigraph, perfusion ventilation scans or MRI. Well, so Dietmar, from my experience, I would not open up the understand to the left side, because from this case, right aortic arch, right RP shunt, of course the left always was the predominant pulmonary artery of perfusion. So I would not open up, and I think it's a big left, of course, and the right now, since they stand it with the Andra, is pretty much okay.
Yeah, the flow looks very,
okay, thank you.
In both sides. Okay, if you don't have any other comments or questions, I will carry on and showing the valve we want to. Yes?
Please move on.
Okay, so our intention is to implant a SAPIEN valve, and based upon the measurements we took on the RV outflow tract stenting, the size of the SAPIEN that we want to implant will be 23 millimeters. Now, if you move to the table here, Luce, okay? In a second, you will see in a close-up, this is the system. Yeah, Roberta is besides me, the product specialist. I'll try to show you simultaneously handle that Roberta will manage. Yes? Okay. Can you see both ends, the balloon catheter where the valve is supposed to be mounted on, and the other end of the delivery system. Can you see
Yes.
that?
That's clear.
Okay, so this is the delivery system for the Sapien XT that we're going to show you in a minute. Just to show you how the system works. Well, the valve will be mounted here when the white
I will have to leave over.
signal is. Can you see that?
Yes.
All right. Then we will advance the system in the IVC in a straight portion, and Roberto is pulling, you see, the metal until you see the click. At that point, the valve should be there, and Roberta, with this black pod, will make fine adjustments. You see very slow movement of the distal portion of the balloon where the valve is supposed to be mounted on. So at that point, the valve is there and ready to be placed. Okay, so let's move. Roberta, can you show the valve here? Or I can do that. Okay. Can you zoom on my hands here?
Yeah, that's nice.
Okay. So that's the Sapien XT valve. You have some green suture here indicating where is going to be the ventricular portion. Well, you see the green suture very nicely when the valve is opened. But when you crimp the valve on the balloon, you're not going to see this green line anymore. So how to be sure that you mounted the valve in the correct position? You see here, there are some 3 distal points, metal, yeah? And a single one here. This is going to be the right ventricular position of the valve. So that's obvious that we have to mount the valve in the correct spot, but of course it's very, very important. Okay, so Roberta, go ahead and we will show you the process of crimping the valve, etc. Yeah?
I will
Okay.
not use clipping. I will cut it open.
Yeah,
Because if we
there
cut
is
it
a
open,
cuff
you
to
will still be
protect
able to
the valve
visualize the left corner.
when Robert is going to crimp. Wait a second, I will approach this crimping tool. Can you enlarge the view a bit more? Roberta, wait a second. Let them show the valve there. Yeah. Can you see the valve inside the crimping tool? Yes. Okay, so go ahead. We will do gradual progressing crimping. Yeah. Okay. Oops. The valve is out.
Take care that you put it in the
Well, we
good
try to
direction.
be, yeah, we try to be as perpendicular as possible to show it better. So this makes our life a bit more difficult. So you see the balloon. Yeah. Yeah. Okay. Can you see? Yeah, I'm looking at the pictures. Oh, can you see that?
Yeah.
Okay, I'm moving the crimper more. Yeah, then that's it. Okay. This is not exactly what I wanted to have. Is that okay? Okay, let's remove the crimping tool and have a zoom on the balloon and valve here. Okay. Yeah. See on lateral. Okay, can you see that?
Yes, clear.
Possible.
The green lines are on the
Okay,
good side.
Roberta, go ahead. So again, we are going to perform further crimping. Okay. Any questions so far?
No, I think it's nice demonstrated for those who are not familiar with the valve. So the valve actually is put on the shaft and not yet on the balloon. And once
that's right. You see,
in the patient, it's
right. That's right. Exactly right. This is the position of the valve close to the delivery system. Can you see that?
Yeah.
So now we are almost ready to go. Before doing that, we have to do something else. Yes. This is a loader, a plastic loader.
He will turn it around. He will see. This is okay.
Roberta, is everything okay?
Make sure that the
okay. Good. So this is the plastic loader to allow the introducer of the delivery system in the short introducer sheet in the groin, which is well, 18 French sheet. Well, these are redundant. We could have used a 16 French as well for 23 millimeter valves, okay? But just in case we wanted to use the 26, that will need to have an 18 French, we already put an 18 French in the sheet. Doesn't really matter. Okay. If you don't have any additional question, we will carry on the procedure, okay?
Please go on.
Okay. So now, can you lower down the lights a bit? Can you go back to fluoro picture, please? Okay.
That's the way she would use it. So you don't have to.
Okay, we have a
No, he is right.
a multi-purpose catheter placed well distal in the right PA. Can you see more distal? Okay, that's the position of, this is a Lunderquist wire. Okay, move back. Okay, I pull back the catheter.
Yeah, ik heb je een, I made a PA as a bookmark where I cutted it over,
Okay.
not use the clipping. Because if I use a clipping, you don't see the LCA which is here. So I have saved.
Okay. Luca, can you bring the, Luca, Roberto, can you bring the
so whenever you have to go
valve
back
here?
to iPilot. And the other one is final. Whenever you have to go back to the most complete where he nicely boards the stents in, take final. iPilot, final. Everything else is no longer important. And now, so you see.
All right.
The left is
can
totally
you
cut
zoom
away.
a bit on the
right
groin
because the
here,
wire is
please?
The shift is totally acceptable. There's not a lot of
Okay.
shift. And I would
Luca is inserting
started.
the delivery
I will
system
talk to Mario in a second, and then I will leave
over the wire.
I forget that the audience probably would like
Go,
to get
go,
a short
go,
impression
advance.
of the iPilot image. They will not see it because the camera is only visualizing what they have in the A plane. Okay? So I will go, tell him this, and then for the rest, I think it's really nice. It's a little bit, it's a little bit trapezoid. I don't know if there are...
Roberta, come close to me. Okay, we are inserting the valve here, yes.
Due to the quality, which is not top,
okay.
you cannot really look into a hole.
Right there.
But for
okay.
it's easier.
Then I just advance the delivery system
it's dominant in the
with some resistance, not that much.
Now you can see the stent and something like an outline of your figure.
Now we will remove the loader, the plastic loader. Okay. So now it's not necessary anymore to see my hands. Let's have a look at fluoro. So, as I told you, well, we have to load. We have to load the valve in rather straight position. So we bring back everything just to make sure we are in the right spot. Okay, so we can go ahead and yes. Luca, store fluoro all the times, okay? Store fluoro.
Mario, short second. I've put iPilot on Leonardo. I don't know if they want to make it visible. You don't have to. You don't have to.
What?
I've put iPilot on.
Yes, okay. Well, before doing that, let's have a look very quickly to the iPilot, so-called iPilot. Mirella, can you show us the iPilot? Look at the 3D. Yeah? Can you go on with 3D iPilot?
Okay, fluo. Mirella? Oh yeah, you're down, that's it.
Here we go.
Okay.
This is a reference to the implantation, yes? But we better go a bit more, let's say, cranial. But before doing that, I will show you how the valve will be mounted on the balloon, okay? So I will advance a bit more the valve to be outside. Yeah? There. Okay. Move the table a bit more. Okay, Roberto, go ahead. Stop there for a second, stop Floro. Okay, now carry on. Well, just a second. Can you see the Floro pictures and picture-in-picture Roberta hands here? Can you see that? Well, you can see, you cannot see very clearly, but well, we will have a large fluoro and a small picture-in-picture of the back of the delivery system. Okay. All right. So Roberto, you're doing fine adjustment with the black pod.
This is the fine tuning where the
Fine
valve
tuning,
is
exactly.
positioned exactly on
Okay.
the balloon.
The valve is between the two markers, so we can carry on. Yes? Okay.
Yes.
Luca, please follow me. Well, just before doing that, let's have a look at magnification of the here, my hands. This is the fluid-filled syringe. As you know, we have to fill the syringe with a precise amount of liquid, which is going to be 22, yeah, or less, 22, 21, 18, 17, whatever. It depends of the size of the valve you want to implant, okay?
Yeah.
So Roberto, carry on. Okay.
Volume controlled.
Let's go to fluoro now. Please follow me. Yeah, let's go to cranial, please. Mirella, more cranial. LAO, more cranial, LAO. Can you show us? Okay. Well, more or less, you have the iPilot on screen. I'm advancing the delivery system. Rather easy, I would say. The valve is more or less exactly at the point we wanted to deploy it. Yes? Any questions so far? Any comments before I go ahead uncover the valve? Stop
everybody
all the time.
Takes a very close look and is really intrigued how quick this runs.
Right. Okay, so I'm going to uncover the valve. This is just to do like this. Keep this. Yeah, pushing the button. Yeah. You want to see my hands or not?
We see your hands and we see fluoro. It's
just
nice.
With my right hand, I will keep the metal part here. And with my left hand, I will go back with the sheath to uncover the valve, okay?
Okay.
Like in ordinary sheath. Well, I think the valve is in the correct spot.
I think everybody agrees.
Yeah? Good. Okay. which is there. We reached the correct position, I would say. So I think we are ready to deploy it, Stormflower. Maybe a fine-tuning, yeah, I mean, it's exactly in the place we want it to be, okay? Ready to deploy the valve? What is important for implanting the Sapien valve is to inflate the valve rather slowly, and when you reach the full inflation, you stay there for 4 or 5 seconds to avoid the recoil. So we will do it on Cine so you can see even better. Okay? Massimo, you're ready to go? Okay. 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 Go. Go, 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 go. Okay. Okay. Deflate. Stormflower. Okay, the hemodynamics are stable. Sinus rhythm, the aortic pressure is up again. The valve is there. And now we are going to take the delivery system out, and we will have the long sheet. All right. Massimo, go ahead and keep the, yeah. We do it slowly, gently. Okay. Okay. You're going to take the delivery system out. Of course, leaving the wire in place. We will be ready to advance a long sheet to do an angiogram. I want to have an 8 French. Okay. Massimo. Okay, delivery system is out. Now we will use a long sheet to do the angiogram, measure the pressure, etc. Any comments or questions about the procedure?
There's a question from Dietmar.
Yes.
Thank you very much, but I'm an old-fashioned man.
Dietmar, sorry, I cannot hear you. Can you shout or increase the volume?
He's walking to another microphone.
Ah, okay. Yes, Dietmar?
There's still connection problem. Yeah, now you're there.
Okay, Mario. I old-fashioned man, you know this. I'm here in Milano to get the new fashion. But I never implanted a valve without the lateral view. It makes me that the benefit of the rotational angiography might be a negative that you don't use the lateral one. But I feel me uncomfortable to implant the valve without any view on the lateral.
Okay,
maybe
we can
only depends on my non-experience.
Well, of course you cannot see all the times in any different views, but just to make you happy, that's the...
That makes me very happy.
That's the appearance in the lateral view. Are you happy with that, Dietmar?
Yes, I'm very happy, but
okay.
I wouldn't implant it without the lateral one.
Right. But you know, in this case, we knew in very detailed fashion any size, any position, anything about... So, well, I actually kept the AP projection because I wanted to show you the mounting of the valve in the IVC, progression of the catheter, and everything in AP. But I agree that usually I also use the lateral view to implant the valve in most cases. Yeah.
There's a question from John Thompson.
Mario, the E-sheath was developed for TAVI, obviously where access size is a real issue, but actually for pulmonary venous implantation it doesn't really matter to us whether or not we have a 18 or a 22 or a 24 French sheath.
Yes.
Do you want to make a comment on that, and in particular...
Well, I think, yeah, you outlined that this is potentially a good advantage, right? This valve is being implanted with a 16 French sheath, which is not, well, in this particular case is not a problem because we can use a 22, 24, it doesn't really matter. But if you have a smaller patient, having a smaller sheath for delivering the valve is going to be useful. Well, can you see the recordings now, the pressure in the main PA? Can you show us, not my face, but the pressure tracing?
Mario, just one further point and question on that. What about retrieving the valve? Because with the previous sheath, if you had to, if you lost wire position, etc., you could get it out of the sheath.
Right, right.
Very, very difficult to do that with the E-sheath.
Yeah, you're absolutely right. This is another very important point, and the major advance is the Sapien XT, which is actually retrievable. The old Sapien could not be retrieved. When you advance the Sapien, the old Sapien in the body, you have to deploy it somewhere. You cannot retrieve it. It's almost impossible, or really very, very difficult. But in this case, with the Sapien XT, you can retrieve it. Okay, so now we have do a test.
What question?
Okay.
When you do the pullback and afterwards there's another question.
Yes, now if you don't mind, I'll do the angiogram first in the main PA, yeah? Okay, ready? 35-18. Okay. Inject. Okay, that's a perfectly functioning valve.
Nice result.
Why don't you have another angiogram in the lateral view just to make Dietmar happy?
Okay.
Okay, let's go. Just a second. Okay, we have some technical problem with the injector. Just a second. Okay, let's do the angio in the lateral view as well. Okay, Luca, go. That's a perfectly functioning valve, yes? Okay, so let's go back to AP. And now what we'd like to show you is the pullback. So let's have a look at the pressure tracing large and the fluoro picture small. Okay, we don't need to see my face, okay? Can you see that now?
Yeah, we see it. We see the pressure tracing and we see the fluoro.
Okay, now I'm going to do the pullback, all right? Okay, that's a pullback. The sheath is in the right ventricle. Okay.
Looks great.
Well, the systolic pressure is barely reaching 25, 28. So pretty normal pressure, systolic pressure in the right ventricle, no pulmonary regurgitation, sinus rhythm, no other issues. So I think we are very happy about the result.
Yes. We'll applaud for you. There's one more question from the floor here.
Yes.
It's really excellent result. My question is centered around while you are pulling the balloon against the valve in the IV inferior vena cava, isn't it there is a risk to avulse one of the cusp or the leaflet of the valve?
The issue is why we pull or mount the valve in the body in the IVC instead of the right ventricle, for example. Because we want to have a straight course of the balloon and the valve. We should avoid to pull the valve back on the balloon on a bend, on a curve. That could be more difficult to do. So it's better to mount the valve in a straight course, in the IVC, of course. And then when it's mounted, carry on and advance up to pulmonary position.
Yeah, because
is that what that was your question?
Yeah, there is one reported patient has such and end up with severe regurgitation and need to implant another valve. You didn't encounter such with your patient?
Well,
whenever you implanted in such way?
Luckily enough, we implanted just one valve in this patient very successfully, and that's enough for today.
Okay.
Yes?
Thanks.
It sounds great. Mario, we have to move to Leuven because they are ready.
Okay, so thank you very much to everybody. Thank to all people helping me in doing the procedure. I'll catch you up later on at the conference room. Bye-bye.
Hello, Leuven. Mark?
Okay, perfect.
Yes. No, I just thought that he was now making the echo and you were allowed